I see the top of the hour.
Good morning, everyone. My name is Brian Leaf, and I'm the Executive Director of the NNLM South Central Region in Fort Worth, Texas. It's my privilege to welcome you to the second day of the Network of the National Library of Medicine 2021 Virtual Symposium, Responding to the COVID Infodemic. We hope you've been enjoying the symposium so far. I know I've been personally inspired by many of the presentations we heard yesterday, including Dr. Vinkupta's discussion of the nuances of how information is messaged in the media, or Kalina Koltai's presentation on how historical injustices have been repackaged to spread information and stoke fears during COVID-19. And then Greg Oren's closing keynote on the ways policies and/or racism have had an impact on AAPI communities is definitely something that hits close to home for me. It all just reinforces the amazing complexity of the infodemic. But what gives me hope are these brilliant minds we've seen that are tackling these issues in innovative ways. Today will be no different. We have another great lineup of speakers and presenters from the front lines of combating misinformation that you'll have a chance to learn from as well as interact with today. Before I go over our housekeeping items, I want to give special acknowledgement and thanks to Tony Nguyen, Executive Director of the NNLM Southeastern Atlantic Region, and his leadership of our COVID-19 Symposium planning team. It's been an incredible amount of work, and I know we're all just very appreciative of Tony's coordination to make this a success. But anyway, on to business. First, this session is being recorded. During all sessions, we have everyone muted to cut down on background noise. If you would like to make a comment or ask a question, please use the chat box and send it to everyone so the person monitoring chat doesn't miss it. We're running on a tight schedule, so we'll end on time so everyone can get to the next session. All sessions are eligible for CE credit from the Medical Library Association, and several sessions are also eligible for the Certified Health Education Specialist credit. We'll be sending out an evaluation at the end of each day. Completing the evaluation is the first step in claiming your CE. And now I'm very excited to introduce our opening keynote, Jess Kolis. Jess Kolis is a health communications specialist in the Global Immunization Division on the Demand for Immunization team at the Centers for Disease Control and Prevention. She has supported CDC's COVID-19 response for the past year, working on the cruise ship task force, social media team, as well as the social media lead for the vaccine task force. Jess currently serves as the co-lead for the Vaccine Confidence Insights Unit, working to synthesize and triangulate media monitoring, social listening, direct inquiries, web metrics, and more to provide recommendations for actions to CDC, federal partners, and state and local jurisdictions to improve confidence in COVID-19 vaccines. Her accomplishments are far too numerous to list without cutting into her time, but prior to her current role, Jess led social media efforts for the flu division in the National Center for Immunization and Respiratory Diseases. Her resume also includes being the communications manager for health and well-being at the Georgia Institute of Technology and the assistant director of health education and promotion at the University of Alabama. Jess received her master's of public health from the University of Massachusetts Amherst and completed her undergraduate at the University of Connecticut, where she studied both molecular and cell biology, as well as urban and community studies. She is a certified health education specialist. She will answer select questions at the end of the presentation. So if you have any thoughts or questions, please use the chat box and be sure to select everyone when you send it. Jess, thank you so much for speaking with us today. The floor is yours.
Thanks, Brian. I'm going to share my screen. Thank you all so much for being here, and thank you, Brian, for welcoming me. My name is Jess Kolis, and I'm a health communications specialist. And as Brian shared, I work on the demand for immunization team in the Global Immunization Division at CDC. Next month, I will have been deployed for full-time for a year working on the COVID-19 pandemic. I've worked on our Joint Information Center social media team, supported the 2020-2021 flu vaccination campaign, and served as the first social media lead for the vaccine task force, and now serve as the co-lead for the insights units on the vaccine confidence team. Even before we knew what we know now, back in late December 2019, in my old day job, where I manage social media and the CDC flu Twitter handle, I began to see our handle getting tagged about reports of mysterious pneumonia in China. The tagging only intensified, and I was actually tasked to pull notable tweets to send to my supervisor in addition to my daily monitoring for flu-related conversations. Little did I know, did we all know, that we would be facing the beginning of what we hope is a once-in-a-lifetime pandemic. I've worked in a variety of roles in both the public health sector and in higher education, but I think my time in higher education is actually what primed me for the work that I do today. I began my professional career at the University of Alabama, where I oversaw a large pure health education program. What is fascinating about college campuses and how they operate is how information flows. It's easy to think about classes and social events, but from a public health perspective, college campuses are filled with misinformation about every topic imaginable. These students were facing the first time being on their own and having to make decisions for themselves. Many came from a world where most decisions about their health were handled by a parent or a guardian, and they had not had to independently think about health and well-being. Their health literacy ranged widely. That is what made pure health education so fascinating and honestly successful. Over the 3 years I spent at Alabama, my program grew a lot, but it grew and remains a successful program today because it was focused on two core things. One, students needed access to credible information in a way that is easy to understand and applicable to their everyday lives. And students were more likely to be receptive of information coming from a peer rather than a formal setting. I think it can come as neither a shock to you or I that they would much rather talk to one of their friends about sexual health than with me. It also is to say that cool giveaway t-shirts never hurt either. And while social media was already a major player on the college campus when I started in 2011, I soon faced new platforms emerging from Instagram to Snapchat. We knew we had to find a voice on these platforms to add health information in the places and spaces where students were. I worked closely with our students to decide what was helpful to post on, what topics resonated the most, what people cared about, and how well information gaps that existed were being addressed. We also recognized that our programming and outreach were just as important as what we were doing online. While we never had an epidemic specifically on our campus, I recognized that our students were always overwhelmed with information, making it very challenging for them to know where and when to turn to for the right information, not just for health, but for everything. The term epidemic was first used in a 2003 Washington Post column during the SARS epidemic, but saw a resurgence after Dr. Tedros Adhanom Ghebreyesus, WHO's Director General, used the term during the Munich Security Conference in February 2020. He said, "We're not just fighting an epidemic, we're fighting an infodemic. Fake news spreads faster and more easily than the virus and is just as dangerous." And while the term infodemic may be relatively new, the concept is not. Information overloads have been documented throughout history as technology advances increase the production and availability of information. Even before the COVID-19 pandemic began, the average adult spent almost 12 hours a day consuming media, from live TV to radio to scrolling their smartphone. The amount of information we are all exposed to and the amount of time we spend on screens on average takes up over half our lives. In fact, how many of us have spent hours just scrolling through our phones out of boredom or falling down a rabbit hole on the internet? There is endless amounts of information for us to see and consume. Of course, with this much information, there is misinformation mixed in. We are aware of this. We have seen fake news being covered as its own topic for years now, but misinformation is not new generally, and misinformation in public health and in outbreaks of disease has been around for nearly forever. The digital information landscape is complex and wide. In addition to credible, authoritative health information, people are exposed to rumors, misinformation, and disinformation. Rumors can be inaccurate or accurate, and unfortunately, it can be difficult for someone to tell the difference. They may or may not cause actual harm. For example, I'm sure you've all heard of a rumor that if you pluck a gray hair, two will grow back in its place. While not true, the amount of time it does take for your hair to grow back could mean that you have more gray hair once it returns. And gray hair is related to genetics. Misinformation is false information. However, its intent is not necessarily to mislead. In fact, a lot of the misinformation that is spread is actually shared out of genuine concern about a specific threat and a want to help friends and loved ones. For example, when masks first became commonplace and recommended, misinformation spread quickly that wearing masks reduced your oxygen levels, could make you more sick or at risk for pneumonia. And then that cotton mask didn't do enough to protect you and were not actually reducing the spread of the viruses. However, countless studies have shown this to be false. But that has not stopped these rumors and these myths from continuing to spread. And disinformation is when someone strategically and deliberately spreads false information. This can be harder to clearly identify. Many pieces of disinformation that are spread are then turned into misinformation by people unknowingly sharing this information because they really just want to make sure their friends and family are safe. This is a tactic used often in vaccines. Even though the link to autism and vaccines has been disproven time and time again, we still see the supposed connection repackaged and spread among new groups of people to increase vaccine hesitancy. All of this leads to an epidemic, and infodemics are a result of too much information in the digital and physical space during an acute health event. They include both credible and authoritative information, as well as false and misleading information. Infodemics lead to confusion, risk-taking, and harmful behaviors. They can also ultimately lead to mistrust in a public health response in the government. After the COVID-19 pandemic emerged, media consumption increased by 60% compared to the 2019 timelines, when the screen time averages for adults even spiked over 13 hours in March 2020. Many Americans reported feeling overwhelmed by the amount of information on COVID-19, especially as they were spending more time on screens than ever before. Constantly changing public health guidance mixed with messages from health authorities contributed to a noisy, crowded information environment where it was difficult for an individual to identify which information was not only accurate and credible, but also fresh and valid. The 24 hours a day news cycle and global nature of our lives also adds to our challenges. While we may be winding down for the day, the other side of the world is discovering new things and reporting new research and guidance that could literally change while we are sleeping. How can you know what you're going to retweet or share is still right? How can you know that it is helpful? Infodemics and the accompanying misinformation can lead to real physical harm. Misinformation spread during the COVID-19 infodemic here in the US has led to increased calls to poison control centers due to the misuse of household cleaning products, ingestion of bleach, and improper use of hydrochloroquine. In addition to the direct harm of some misinformation, people's vulnerability to misinformation may also make them less likely to adhere to preventive health behaviors. People can be vulnerable for a variety of reasons. It could be low health literacy levels. It could be because their personal core beliefs, or it could even be personal concerns and issues. For example, you may be more at risk for believing misinformation about weight loss if you spend your whole life struggling with body image or an eating disorder. Vulnerability looks different to each person. In infodemic specifically, misinformation can affect a person's risk perspectives and attitudes about a disease, and can lead to them engaging in health behaviors that place people and communities at risk for disease transmission, which in the case of COVID-19 has resulted in failure for many to fully embrace non-pharmaceutical measures, such as mask use and social distancing. As the pandemic has progressed and the vaccines came into the conversation, misinformation began to spread about COVID-19 vaccines too. Misinformation about vaccines is not new. It has been around for hundreds of years. Vocal vaccine deniers have been fighting childhood vaccination for years, and the same tactics are being leveraged for COVID-19 vaccines. Organized anti-vaccine groups have taken to collecting stories of individual tragedy and using them to convince others who see themselves in the tragedy to join what they see as their fight for medical freedom. In context of COVID-19 vaccines in the US, where high uptake is needed to move us closer to the end of the pandemic, maintaining public confidence in vaccines, vaccinators, and the health system is critical. Given the practical issues with vaccination on a national scale, it makes addressing the COVID-19 epidemic and the misinformation about vaccines paramount. Misinformation about COVID-19 vaccines is especially concerning as it seeks to polarize the topic and exploit people's and communities' fear and distrust in the government and the health system generally. It also makes it difficult for people to find, distinguish, and act on credible information. In the last few months, we have seen misinformation circulate, alleging deaths directly caused by COVID-19 vaccines, misrepresenting VAERS data, which is the system CDC and FDA use to track adverse events for all vaccinations, claiming mRNA vaccines can alter your DNA, arguing that vaccines can cause miscarriage and infertility in both males and females, and so much more. In an infodemic, credible, authoritative voices must compete for attention against misinformation that is packaged to provoke strong emotions and take advantage of how social media platforms have been designed. However, it is so much more than having a more prominent share of voice or flooding people with the right messages that is needed to address health misinformation successfully. The information environment we all inhabit is shaped by the media, the social media platforms we access, and our social networks online and offline. We need to build health and digital literacy at individual and community levels because most misinformation is shared at interpersonal levels and gains traction in specific communities, whether online or offline, where information is shared and conversations take place. Understanding themes of misinformation and information gaps that exist, and then developing programmatic and communications approaches that address these underlying narratives is critical to better address the challenges of the infodemic, and especially important in my work to promote vaccine uptake. Chasing individual pieces of misinformation in attempts to debunk them ignores the real, larger social and cultural forces that cause these pieces of information to emerge and gain traction in the first place. One's pre-existing attitude about a particular topic often determines how much they would be willing to believe a piece of misinformation, even after it has been retracted or debunked. Misinformation that aligns with someone's personal belief system and current attitudes is more difficult to correct, and in many cases, debunction can actually backfire and strengthen an initially held belief. We've seen time and time again on social media platforms, back and forth efforts by pro and anti-vaccine groups that never reach an understanding or actual resolution because vocal vaccine deniers are not movable. So while we need to continue to work with tech companies to help slow the spread of misinformation and limit the number of people exposed, we also need to shift our thinking toward what we can do to make less people vulnerable to misinformation if they do come across it. Social inoculation is a framework that comes from social psychology and is based on the idea that we can preemptively build cognitive resistance against mis and disinformation. It works by identifying and deconstructing rumors and misinformation that we can potentially be exposed to in the future. So our psychological susceptibility to taking them at face value is reduced. Social inoculation has been successfully used to promote behavior change in public health in areas such as smoking initiation, prevention, and HPV vaccination acceptance. Communication strategies informed by social inoculation can be especially useful in infodemics for addressing rumors and misinformation that could lead to adverse health behaviors or, in our case, negatively impact vaccine uptake. One major challenge in doing this is determining where to start. As I said earlier, I have been deployed in a few roles on the COVID-19 response. My most recent role, co-leading the Insights Unit, came out of a need that developed when I was the social media lead for the task force. I was facing my own personal infodemic. It was difficult to balance being responsive to the information gaps and misinformation I was seeing spread online and the outpouring of new content from our task force, while also trying to balance the message fatigue that I knew consumers were facing. I also had to be cognizant of the fact that people were not able to access the vaccine in many capacities, and the eligibility requirements were so limited that I did not want to over message when people couldn't even get vaccinated if they wanted to. Social listening tools are not built to help us track and recommend action around public health crises. So our insight student was born. Our COVID-19 State of Vaccine Confidence Insight Report looks at multiple sources to help us better understand the communication landscape surrounding COVID-19 vaccines. To develop the report, we look at social listening data from social listening tools, hand search closed network social media platforms like Telegram and TikTok, analyze comments on our own social media channels, monitor the stories in media and track the media requests we see coming in, review current polls and new research published in peer-reviewed journals. We analyze calls and emails into a CDC's call center, CDC Info. We also track the web metrics, and we're currently looking to see how we might be able to leverage Google Trends data. After collecting and analyzing each of these inputs separately, our team comes together every other week to triangulate what we are seeing. This is especially important as it allows us to weed through the noise and figure out what major themes are rising to the top in this hectic digital landscape. Additionally, as we have been doing this since early February, we are now able to better identify emerging themes before they become major themes and problems. What makes our work different from typical social listening and media monitoring reports is that alongside the narrative for each theme, we share ways to take action and address the information gaps, perceptions, and rumors that may have led to these themes emerging. Often the ways to act are lumped into categories related to communication and education, outreach and working with trusted messengers, and needs to support additional research to better understand the concerns, perceptions, and motivations of consumers. This work is part science and part art, as there is no way to determine what necessitates a threshold for a theme or emerging topic. Since the report began, we have seen the conversation shift and change drastically. Our first report heavily focused on how frustrated consumers were with state and jurisdictional eligibility requirements and the lack of clear communication about who was eligible and why. However, the groups who were eligible were facing systems that were difficult to navigate and were not able to handle the high volume and demand that did exist. We even saw the beginning of conversations related to the impact of various virus variants would have, which was coupled with the need for better education about what vaccine effectiveness numbers meant more generally. We also saw the beginning of confusion about maintaining mitigation measures after vaccination and confusion about what we did and did not know at the time about asymptomatic transmission of the virus among those who had already been vaccinated. This was especially challenging as it began to make many people think that vaccines were not the path out of the pandemic and into normalcy, and challenge the benefits of vaccination that are often the most powerful internal motivators for vaccination. The confusion about vaccine benefits continued into our second report, where we were seeing people more confused about whether one shot might be enough or they needed two, and did previous COVID-19 illness play a role in whether or not they needed to be vaccinated, or maybe they just needed one dose. With new studies on the vaccines coming out what feels like daily, research finding and official recommendations were getting lost in translation, and consumers did not know where to turn or what they needed to do. In report 3, this led to us seeing conversations about people wanting to mix brands of vaccines in order to increase their effectiveness, even though that is not how it works. And people began to actually shop for specific brands that they wanted for their own personal reasons. And those reasons varied widely across each vaccine. I could go on and on. What we have learned has allowed us to inform content, update guidance, expand our work with partners, and support additional research opportunities. These reports have been shared internally, but also with states and jurisdictions, partners, and others at request. And they're even have gone overseas to our colleagues at WHO and in the UK. With our distributions growing by the day, the overwhelming feedback we receive is that this paints a picture that not only validates what many people are seeing or hearing anecdotally, but our ability to find misinformation and perceptions that are in the middle of the pack and highlight them helps health departments and organizations know where to focus next, what the needs are going to be, and work more towards social inoculation so we can try to be there rather than just chasing our own tails. I'm not going to lie, this is a lot of work. There is no silver bullet. It is an imperfect science and one that is very much in its infancy. There is so much information available, and it can be challenging to look at all of the amassed information and think, how do I know where to start and determine the right types of actions? Starting to listen both online and offline in your communities is the first step to getting a hold of this epidemic. It is overwhelming at first. There is so much content, so much to wade through, so many mechanisms to set up. However, even if you have limited access and means, social listening and media monitoring are a great place to start to get a better picture of the challenges your communities are facing. In order to identify misinformation as it emerges, we need to better understand the noise that fills the digital landscape so you can determine what direction to look in for your efforts. There are lots of ways to do this. If you have access to a social listening or media monitoring tool, great. Setting up search strings to track conversations over time is a great way to quantify the conversations you are seeing and better understand which conversations are taking up the most space. However, if you don't have a means to do formal listening, you will still be able to do native searches on public posts on Twitter, Facebook, Instagram, and more. And there are even some free tools that you can use, like Google Alerts, that will deliver the latest information right to your inbox. Track your local leaders, your news stations, and your own social media accounts. Are you seeing common themes, questions, concerns? Also, consider what you can do offline. Is there a space you can do a listening session? Can you have informal focus groups to better understand points of confusion or concerns? While there is so much in the online space, listening offline can be just as helpful in helping you silence the noise as you search for areas that you could help in. This will allow you to start building out materials for pre-bunking and moving in a direction that focuses less on what is top of mind and on retractions and corrections, and more on empowering people with accurate and credible information. There are so many ways to classify misinformation and determine the best way to respond. Pictured here are tools from UNICEF, the UK's Government Communication Service, and WHO Euro on ways you can consider thinking about addressing misinformation you hear and how you could consider acting. I know these are impossible to see, but I wanted to illustrate that there are many different mechanisms to look at the information you are collecting and deciding how to act. For the UNICEF tool on the far left, related to misinformation on vaccines, it breaks down the different areas of vaccine confidence to consider. How widespread is the misinformation you're finding? Does it affect the public's trust in the government or our health system? Is it likely to spread further? How high of a risk does it pose to vaccine demand? The UK's resist tool in the matrix in the middle includes thinking about what types of people should be involved in responding to each category of threat, depending on its risk level. And WHO Euro's tool on the right for dealing with vocal vaccine deniers and conspiracy theorists breaks down the type of conspiracy and what area of vaccination it affects, so that you can determine the appropriate type of content to develop in response, and then also allows you to consider different tactics to respond with that content. For the COVID-19 State of Vaccine Confidence Insights report, I like to look at what fears, concerns, or information gaps and voids are causing particular misinformation pieces to emerge. Is this circulating because people are concerned about safety? Are they confused about what vaccine effectiveness is? Would it be helpful to educate people more on the benefits of vaccination or a specific benefit of vaccination? Especially in working towards social inoculation and pre-bunking, we need to think about the core concerns and gaps that exist so that people who do not yet hold beliefs are exposed to credible and accurate information first. Once you have figured out the best way to act, you need to figure out how to act and with whom. Misinformation is often an opportunity for dialogue. Equipping trusted messengers for online and offline conversations is critical to pre-bunk, address misinformation, and fill information gaps. Trusted messengers and influencers operating in trusted spaces can most effectively deliver messages and strategies and validate the credibility of information, like my peer health educators at the University of Alabama. Trusted messengers and influencers come in all shapes and forms. They can be members of local government, faith-based leaders, community health workers or healthcare providers, state and local leaders, and even community influencers like local news talent. Using these individuals as champions and ambassadors for health is pivotal for the COVID-19 epidemic and vaccine uptake, but also for future health epidemics. For COVID-19 vaccination, people who are definitely or probably going to get vaccinated are more likely to know someone else who has already been vaccinated compared to those who probably will not or definitely will not get vaccinated. This illustrates how important one person may be to one's decision to get vaccinated. I'm sure in your head, as I've talked about this, you've already thought of some trusted messengers and influencers in your community. Identify them, track what they're saying online, and reach out to them. Be a partner to them to make sure that they have the answers to their questions. They are not going to be able to advocate to their communities and on your behalf if they have their own concerns and questions that are unanswered. I'm sure you are also thinking about what we can do going forward. The COVID-19 epidemic is not the first epidemic, and it will not be our last. We need you to be champions for health literacy in your communities. In August, Healthy People 2020 updated its definition for health literacy to include two types of health literacy, personal and organizational. Personal health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. These new definitions emphasize how important it is for people to be able to use health information rather than just understand it. They also focus on a person's ability to make well-informed decisions rather than just what the right decision is. And lastly, they acknowledge that organizations have a responsibility to address health literacy issues. Limited health literacy costs the healthcare system money and results in higher than necessary morbidity and mortality. Increasing health literacy could help to reduce how vulnerable people are and how likely they are to believe mis and disinformation if they are exposed to it. You can be our champions. Your work every day helps people learn and be more informed, and you are in the right place and right time to help people gain the skills they need to protect themselves and their communities against mis and disinformation. I know I've shared so much with you over this time, and I recognize that I'm also a very quick talker, but I hope it leaves you hopeful that there is so much that we can do in this space. Overall, there is no silver bullet for addressing infodemics. The tools we currently have are not built for public health. And while it's a burgeoning space with a lot coming in the future, it still leaves us limited in how we do the work today. Debunking and reducing misinformation online and offline is only one tactic, and it ignores the real larger social and cultural factors that have caused misinformation to emerge and gain traction in the first place. And while we must continue to work in those spaces, we must simultaneously work to reduce people's susceptibility to misinformation on the whole. We have learned throughout this pandemic that traditional risk communication strategies and social media approaches are not sufficient. We have had to rethink who we utilize to spread credible and authoritative health information, as well as how we can address the nuances of information gaps that exist, especially considering how different populations have different information needs and gaps. I've had the opportunity to talk to a lot of companies lately, and it's been very interesting to hear the work that they're doing and how they want to be in the space of helping to amplify those credible, authoritative platforms and people. And also in recognizing that that's not always the traditional people you think. It is not always going to be CDC or a local health department who we should amplify. Often people who are hesitant or less likely to want vaccination are actually looking to healthcare providers or other community level influencers. And those are the right people at the right place who really need to be amplified to share the correct messages. In order to address the COVID-19 epidemic and prepare for future health epidemics, we must use evidence-based approaches, leverage social, behavioral, and epidemiological insights, and execute a plan transparently to reduce the spread and harm of misinformation and promote accurate and credible information. And we need all of you to do that. We need your help to build health literacy in your communities and help trusted messengers in all forms to share the right messages in the right place at the right time. You're all well equipped to be ambassadors and advocates in this space. And I hope you leave inspired with an idea of one way you can address the infodemic in your community. And if this is something that you find yourself really called to do, WHO and CDC are partnering to host the second WHO training in infodemic management this June, and the call for applications just opened. Myself and my colleagues are working on developing the curriculum as we speak. And these trainings are going to help build infodemic managers who measure and monitor the impact of infodemics during health emergencies, detect and understand the spread and impact of infodemics, respond and deploy to interventions that protect and mitigate the infodemic and its harmful effects, evaluate infodemic interventions and strengthen resilience of individuals and communities, and promote the development, adaptation, and application of tools for the management of infodemic. Thank you all so much for your time. I'm excited to take some questions and engage in conversation and discussion.
Thanks, Jess. This is Rebecca. Not too many questions have come in so far, but hopefully some more will. But of course, we did get the proverbial question of, will you be sharing your presentation? And I know we could put that as a PDF.
Yes, I am able to share it. It was cleared, so it is able to be shared. So we will definitely share that.
Okay, and so folks who do want that, and for all the presentations that are shared with us, they will be posted within the agenda that can be found in the symposium lobby, and I believe they'll be available in that location for 30 days. So, okay, so that's that. Here's a question. Is an infodemic influencer a professional term?
Infodemic manager is one that we've been working with WHO to start to hopefully have organizations all over the world work in this space. And there's some government organizations that are building out spaces for this. My role very much is in an infodemic management space, and it's actually what my specialty is for our group in my day job. But for an influencer side, I think that's it's an interesting question because no, there's no one is going to be an infodemic influencer. And influencers, I think a lot of times when we say that, we think of the large scale celebrities that exist. And I feel like we all have to recalibrate what an influencer is. And oftentimes what we're recommending people do is work with micro influencers. What you are not more likely to believe something from a celebrity, but you are more likely to trust someone you know who's sharing credible information and that the information they're sharing with you is valid. And that's especially why mis and disinformation is challenging, because you have people who are your loved ones, your trusted messengers for your own personal life, and they're sharing misinformation that they may think is true. So we really have to work with people on a local level. And one of the things we're doing at CDC is we are working to help states and jurisdictions identify someone to do the work that I'm doing on their local level, so that we can more easily assist states and jurisdictions in finding those people and helping to address infodemics on a more localized level and among specific communities.
Okay. All right. So next question, how to best convey that policy or guidance is applicable based on knowledge at the time, current knowledge. How to deal with accusations of flip-flopping.
Yeah, I think one of the things, a major pillar of risk communication generally is sharing what we do know and we don't know. And I think one of the pieces that we all need to do better on is when we're sharing information is making sure we're acknowledging what we do not know yet. I think there's a lot of people who feel the guidance for fully vaccinated individuals from CDC that says now we can gather in small groups on masks and we can travel is flip-flopping because we didn't say that in January, but we didn't have the data in January to say that. So I think we need to do a better job educating people about what we don't know when we share information and what we're working towards. The classic risk communication space is saying, what you don't know, and how you're working to find out what you don't know. So we all need to do a better job of sharing that whole picture, which I know on social media is exceptionally challenging. I know I've written tweets and we know that people only read the first tweet of a thread. So it's exceptionally challenging, but we do need to do a better job acknowledging what we don't know. And unfortunately, that leaves a lot of people feeling concerned about those information gaps. And that is where rumors begin to grow. But if you have enough people enabled to say, that isn't what this recommendation is saying, they don't know, it wasn't a flip-flop, they didn't even have the data to say that. We need to be able to equip those people to talk about that. Science does grow over time. As we get more data, we learn new things, and we're able to provide clearer guidance.
Thank you. All right. So another question, are you also working to let government understand that they need infodemic managers in addition to you?
Yes. Yes. So it's been really great, honestly, to be in this role because myself and one of my colleagues, Liz Wilhelm, we kind of came up with this idea. She had been working with the WHO on infodemic managers, and I think no one really knew what that could be. And I think the challenge was everyone thought we just needed to collect more and we needed to look in more places. And we really took a step back and said, do we actually need more of this? Do we need to do more listening? And I was like, I don't even have time to look through all of the inputs I get emailed to me every day. And in my first week on the job of this deployment, I literally just spent having meetings and emailing people with all the different things they were doing. And you know what? We are still adding inputs to our report in the work we're doing. We are working very hard to not just build this out for the response, but to build it out for all of vaccine confidence. We know that this work applies to vaccine confidence broadly, but also that these systems we're setting up are ones that can be applied in other places. And we are talking with WHO as well as partners in the UK. And in my day job, I work with other groups that are doing this globally, that we need to have those networks and we need to have a better understanding for approaching everything. And it's been really great to be at the table for conversations with the tech companies to suggest that we need to shift how we're thinking, and the tactics they're doing are great and they need to continue, but what else can we do to move this further? Because as you all know, this is not the first infodemic we will face, and hopefully we won't have another pandemic in our lifetime, but there will be other infodemics. We just look back to Ebola and others that we are always going to be overwhelmed with information. So how can we build out systems that create more resilient people is going to be a key. So we're working there. And I think helping to get states and jurisdictions funding for staff to do that work will be a next key step. I also think there's a lot of great partners who are working to do this as well. And so I think one of the things we'd really like to build is a community of practice here domestically that we could leverage to do this work in a coordinated way.
Okay, so let me see here. So one person said that, I don't remember if it was a male or female, he, she. I'm looking forward to reviewing all the algorithms and information you've provided. I find that a common refrain on Facebook when I share legitimate information, from CDC, she said AAP, I'm not sure who that is. So the refrain is, well, all of us can find information that supports what we believe on the internet. And this is technically true. Do you have suggestions on how we can respond to that?
It's super complicated. And because as I shared when I talked about social inoculation, is that it's really difficult to challenge someone's core belief system. And they're already, misinformation can validate their core beliefs in a way that even debunking wouldn't work or change their mind. It would actually make them more hardened in their thoughts. So one of the pieces is that we need to do better about educating people about sources and how they identify their sources, and how they're determining what is accurate. And it is true. I think there's a lot of people who, you can find, when we do our reports, we try to make sure that the data is leading our themes, because I can go and find a tweet on anything. If I wanted to highlight a theme in a report because I had a personal agenda, I could go to social media and I could find it and make a story around it. But that's not what we want. And that's not our goal. We want to make sure that what we're seeing is being led by the big picture, right? And so I think that the conversation would be breaking down of like, well, what sources do you use? Why are you using them as your sources? And approaching it from a way that is trying to better understand how they're choosing what their credible source is, and how they're selecting their authorities. And then this speaks to the side of the conversations we've been having with Facebook, specifically about who we're amplifying. A recent study, or recent piece of data that we have from the surveys we're working on internally at CDC, found that people who are definitely or probably not going to get a COVID-19 vaccine do not trust CDC, their local health departments, and their local news, mainstream news. So, but they do trust their healthcare providers, and they do trust a few other categorical influencers. So those, instead of having our post, CDC's post, or a local health department's post, promoted to those people, we actually need their personal physician to have their post promoted to them. And there was a recent study that came out that showed that even people who had very strong anti-vaccine beliefs, when they were given scientific information from a trusted resource like their healthcare provider, and they were given time to talk through what the science said, they actually changed their mind. So it's a combination of being willing to say, can you tell me more about who informs your belief system and who is your credible sources? And then let's talk about where you're getting your data and where I'm getting my data, and like, what are the intersections, and work to talking through that scientific piece. And we also know that scientific looking misinformation is more likely to be shared and believed than categorical story-based misinformation. So the tactic is to fight science with science, but it's also to have this understanding conversation of understanding why someone believes that particular, and approach it from a sense of educate me about what you're seeing and how it's informing your belief system.
Okay. Let's see. Can you share more about how you evaluate the success of interventions to the misinformation that you're tracking? Are you using social listening to see if the chatter goes down, following specific accounts to see if their messaging changes?
Right now, we're doing a couple things. We are looking for vaccines, so I can speak directly to what we're doing for vaccines. We are tracking conversations over time. We do, unfortunately, a lot of the tools, sentiment analysis, are not the most accurate. So we do a lot of hand combing in anecdotal qualitative analysis, because honestly, the amount of content we're looking through is pretty impossible to do on a full quant data with our turnaround time. But we do track all of the themes. So if we've highlighted a theme in our report, we track it every other week. And so we like to watch how it's evolving, because often the information is not going away. It's just how it's packaged is changing. So for example, one of the interventions that we're going to watch over the coming weeks is that CDC just put out a new consumer-facing webpage about VAERS data, which explains what VAERS data is, how it works, how it is not an actual true adverse event. It's how CDC follows up on true adverse events and then determines if they are. This is the first time we've had that type of content, and it came out of our recommendation that we need to do something to better communicate about what VAERS is and what it does. So we're going to be tracking the conversation over time to see whether or not we're starting to see a shift in how VAERS data is talked about, given that corrective messaging is in place. And that's something that has long-term impacts for vaccination as a whole. So it's something that that will be important to watch over time. So that's just a recent example. And we've been doing this and putting out these reports only since the beginning of February. So we're still very much in the evaluation phase. We are standing up an evaluation more generally on the Insights report to better understand how people are using it and how to make it more helpful to the work they're doing as well.
Great, thank you. We're getting close to end time, but we do have a few more minutes. So here is another question. This person asks, I'm going to be working with our college students on COVID vaccine outreach. How do we address COVID vaccine messaging fatigue? There's videos, pamphlets, etc. Fatigue that I've noticed from speaking to different stakeholders. So what are the best vaccine outreach tools that you think we should explore?
Yeah, I think so. Interestingly, back when I was in the Joint Information Center social team, we did a whole analysis because we saw fatigue happening already in the pandemic in June 2020. I think it's really great to take an evaluation of the messages that you are already putting out there. I think it's really easy to look on surface level and say what posts are performing well and what's not. But really, you need to be looking at the different types of messages, how it's packaged, the graphic asset, and where it's going to better understand what's hitting and what's not. Rapid A/B message testing, I think, is something that we need to do better at deploying. I think we're also worried about putting together this full package of graphics and beautiful things that we don't necessarily think about putting out multiple variations of the same item to see what performs best. And a lot of what equals good performance in some ways is what's shareable and what can go viral. So really identifying what people are most likely to share. And for college students, I think it's really, they're the most willing to get into the room. And I think one of the interesting pieces that we're seeing is that there's a general disinterest in COVID-19 vaccine from Generation Z, and they in particularly they have a lower risk perception for COVID-19, but also they're over it, and I can recognize that emotion. I think anyone who has small children can, but the pieces of what's going to benefit them are really important. And talking about hospitalization rates going up in different populations is that you really just need to find what's that value statement for them. And peer influence plays a large role. So I would say for college students is to do a lot of A/B testing, but also take stock in what you've done already and really see what has performed well, what has been shared a lot. Are there specific styles of graphics or assets? Are there platforms that are performing better than others? And who are the right people to doing those messages? Is it that you need students on the ground to be the one doing it? Are professors influential? And that's going to look different on every single college campus.
And I think you've touched on this, well, maybe not, but do you recommend community health workers, such as yourself, as influencers?
I don't know if I view myself as a community health worker, because I think at the federal level, we're very anonymous. But yes, healthcare providers, particularly family practitioners, are the most trusted source for information related to vaccines and the most likely to convince someone to get a vaccine. I do know that there's a lot of people out there who are waiting for vaccines to go to their home offices where they will feel more comfortable to get vaccinated. So, but doctors and other providers as well. We recognize that healthcare workers working at the front desk or nurses or medical assistants, all the people involved in healthcare play a vital role in encouraging vaccination and influencing the epidemic and fighting that. They're also the front lines of the ones who are hearing everything. I always find when I go to a doctor's appointment, because most of my physicians know what I work on, but we end up talking about what they're hearing. And one recent one talked about how he heard a colleague who's also a healthcare provider didn't want to get a vaccine, didn't trust it, didn't believe in it. And he works on the Olympic team, and he was like, so you want to be the one who's getting Olympic athletes sick? And I guess that was his aha moment. So, but we do know that there's hesitancy among healthcare workers more broadly as well. And so the ones who are very engaged are wonderful. And I know we're working with the group from #ThisIsOurShot to help give them insights so that they can put out content. There's about 12,000 healthcare heroes that work for them that are doing messages related to COVID-19 vaccines and more, COVID-19 more generally, to help encourage their patients and communities. So they're definitely a great space, especially the ones who are digital natives and can go places. I told them, I was like, wow, I love the stuff you're doing because we could never do it for our channels. And it makes me really excited that people are thinking outside of the box. And I think healthcare workers are the most in tune about what their patients and their communities need.
Great, Jess. Thank you so much. We're at time now. I know there have been a lot of questions, a lot of great discussions. Thank you for your recommendations and all the great tools you shared as well. I'm going to put your email in the chat one more time for people that want to contact you later with more questions. And I believe there's discussion of your slides being up at some points as well. So thank you for your time today. And I hope everyone will join us in the next sessions.
Thank you all. Have a great rest of your day.
Thank you, Jess.